Pharmacology, 12 to 18% of your Nclex. Again, very important topic, very important concept to make sure that you understand. We're going to really focus on pharmacology, making sure you know how to use it, key test taking strategies, so that way you can make sure that you're going to be giving your medication like a boss. So 5 questions utilize the 5 medication rights, and of course, allows you to use your knowledge on appropriate ways to give medication, right? So utilize the following assessment guidelines. Always make sure you're assessing, right? Number one thing you learned in nursing school right after you ask for name and date of birth: allergies or hypersensitivity to a medication, right? Any existing medical disorders that are contraindicated. We look at potential interactions. Pertinent lab values, of course, like for example, Coumadin, right? I'm looking at the INR. If I'm giving Lasix, I'm looking at the potassium, right? Vital signs, right? Especially for cardiac and those BP meds. Intended effects, right? Therapeutic effects. Why am I giving this medication? The side effects, okay? Again, a lot of GI side effects, right? Doesn't kill anyone. Like the adverse effects are things that are killer, right? And those complications are what kill people. And then, of course, those toxic effects, right? So we put adverse and toxic effects together. And then, of course, the client responds to those key medications, right? So we always want to make sure that we're keeping all of those things on the forefront whenever we're dispensing medication. So the nurse notes that a physician has prescribed quatrimoxole, which is Bactrim, for a client with a urinary tract infection. Which priority action will the nurse take before administering this medication? Remember our test-taking strategies for priority questions. So is it 1, call the pharmacy to order the med? 2, ask the client about an allergy to sulfonamides? 3, check the medication supply room to find out whether the medication needs to be ordered? 4, inform the client about the need to increase fluid intake. Our test taking strategy with priority questions, right? We always focus on what? Life, death, airway, breathing, circulation, right? So number 2, right? The action, priority action, right? So the issue is the action that the nurse will take. Our key word, remember, always look for those key words, priority, right? So the next step of the nursing process will help you here. Option 2 is the only one that addresses this client's assessment. I need to make sure I assess before I give the medication. And part of our 5 rights too is to making sure that we've addressed our 5 rights, and of course making sure if we know if the patient has any allergies, right? Because again, anaphylactic reactions are real and people die every day. So we want to make sure that we do our due diligence and prioritize our patient safety and care, and knowing that we always assess for allergies. A client is taking amitriptyline, Elavil, calls the nurse at the physician's office and reports that he has an upset stomach whenever he takes the medication. The nurse most appropriately tells the client to 1, take the medication with an antacid, 2, stop the med for 2 days and then resume the prescribed med schedule, 3, take the med on an empty stomach, 4, take the medication with food. So what are we looking at here? Again, 4, issue upset stomach. So remember, antacids are not usually administered with medication. So a nurse would not tell a patient to stop taking the medication, right? And I remember I told you a lot of the most common side effects are GI issues, right? Nausea, vomiting, upset stomach, right? So in this instance, we're going to remember to tell them, of course, to take it with food. Important to know, you have to know the difference between, again, intended effects, right? That's a desirable effect, why we're giving the medication. Then there are side effects, right? Which are not desired, but they're not life-threatening, okay? And they're usually alleviated with specific measures, right? If it gives you an upset stomach, okay, take it with food. Adverse effects are the more severe, right? Issues that arise. They're more severe than a side effect, right? They're always, again, I know we don't use absolute, but adverse effects are always undesirable, right? So always report to the healthcare provider. Toxic effects, of course, medication levels in the body that exceed the therapeutic effect. Like that's why it's so important. We're going to talk about knowing your levels, like for digoxin and amniofilin, right? We always want to make sure that we know if a patient has too much of a drug in their system. Erythromycin and mycin has been prescribed for a client with a respiratory infection. The nurse tells the client that which frequent side effect can occur from this medication: yellow discoloration to the right part of the eye, abdominal cramping, severe diarrhea, or yellow colored skin. Focus on the key issue here, right? So again, we eliminate options 1 and 4. Test taking strategies. First, because they are similar, right? The yellow, yellow, jaundice, jaundice, right? And both indicate the presence of hepatitis, an adverse side effect of the medication. We're not looking for an adverse effect. We're looking for what? Side effect, right? We also eliminate option 3 because of the word severe. Remember, if anything says severe, right? Or copious, large, right? Those are things that indicate something is really, really, really wrong, right? Which indicates an adverse effect. So remember, we're paying attention to what the question, what the STEM is asking us for, and it was a side effect. Again, side effects are often undesirable symptoms, but they're not going to kill me, right? So again, a little bit of abdominal cramping, okay, is a side effect. A client with congestive heart failure is receiving furosemide, Lasix, right? One of your favorites. The nurse monitors the client for which adverse effect of the medication. So let's see if you know the adverse effects of this common loop diuretic. Is it nausea, increase in urine output, gastric upset, or muscle weakness? You got it. Adverse effect, right, is muscle weakness, right? So test taking strategies, we're eliminating 1 and 3 because again, they are similar and both relate to the GI system. We eliminate option 2 because is it an intended effect of the medication? Why am I giving the medication? To increase urinary output. So that's exactly what I wanted to do. So again, you can see the difference between when it acts for a side effect versus when it acts for an adverse effect. So unfamiliar with the medication, these are some good tips and tricks for you to know. Note whether the question identifies the client's diagnosis. For example, if the question states cyclophosphamide, right? Cytotoxin, that's been prescribed for a client with metastatic breast cancer. Focusing on the client's diagnosis will help you determine what the medication is for. It's an anti-neoplastic medication. How would I know that? They told me she has breast cancer, right? And you can break down the names, right? So remember, boards are usually going to show you the generic name. So for example, terbutaline sulfate, which is breathine, right, has been prescribed for a client. So think about breath, right? When you look at the medication named breathine, it helps you determine that it is a respiratory medication. Again, note the letters in the medication and look for these letters that identify a particular medication class. Pharmacology questions break the name down to help you. So let's look at this one. A clinic nurse is taking a health history on a client seen at the healthcare clinic for the first time. When the nurse asks the client about current prescribed medication, the client tells the nurse that indinavir, right, Crixvisban, is taken twice daily. Based on this finding, the nurse suspects the presence of which condition? Is it 1, peptic ulcer disease, 2, inflammatory bowel disease, 3, HIV, or 4, diverticulitis? Now, this is going to be an important part of your studying and test taking strategy. Did you note anything in the name? Okay, the suffix, prefixes are always going to point you and help you figuring out the medication. So again, keyword suspects the presence, right? The issue nurse's findings. So remember that many antiviral medication names contain the letters what? V-I-R. So the VIR is for what? Virus. This will directly lead you to option number what? 3. So note the similarities in options 1, 2, and 4. So another test taking strategy would be the odd man out. All the other ones have GI what? GI implications, right? So again, you want to focus on the VIR. All viral medications have VIR in the name. So how do I study pharmacology? How do I master this material? Know your classifications. I can't stress that enough. So it's going to be very important. So you can see that this is a following list of major drug classifications with memory tricks, right? So your anti-anemics, right? So it's for the prevention and treatments of what? Anemia, right? Anti-anginals, right? And angina is pain, against pain, right? So again, it's very important when you look at medications and know their drug classifications because they help you figure out exactly what they are for, right? So for example, our anti-anginals, right? Against angina, against chest pain. Our nitrates, right, are used to treat and prevent attacks of angina. Acute treatment, our calcium channel blockers and beta blockers, those LOLs, are used prophylactically for long-term management, right? So it's very, again, antidepressants, obviously for depression, right? Anti-diabetics, right? For patients with diabetes. So it's very important that when you study your different systems that you learn the drugs by their drug class. It's very helpful and it makes your life with pharm so much easier. Adverse effects of a drug class or type, right? So let's look at a couple common examples and how you should be studying and learning these medications. So take antihypertensive, right? So some of the common things that we see, of course, are orthostatic hypotension and fluid electrolyte imbalances, right? So just based on some of the things that we see, right, with the effects of the drug. So their blood pressure changing and dropping when they go from a sitting to a standing position, right? Electrolyte imbalances with, of course, potassium, sodium, those key things. Those help us keep in mind what should we be doing and anticipating because of some of the side effects and adverse effects, right? So with antihypertensives, I remember our ABCs are ACE inhibitors, beta blockers, and calcium channel blockers, for example, right? And our diuretics, ABCD. Assist with activity, eliminate drug interactions. Again, vasodilators, right? So they drop the blood pressure. Central nervous system depressants. You're going to monitor their blood pressure, their pulse, their respirations. You always want to make sure that you're checking their lab values, their serum electrolyte levels. You're going to assess their breath sounds, right? If they develop any edema, dizziness, right? You want to make sure that you're assessing for those things. And you want to help with the teaching, right? Help them to get up to stand, reporting dizziness, avoiding alcohol, any other medication that can cause sedative effects, right? Over the counter medications like Benadryl and cough medicine and cold medicine actually can drop the blood pressure even more, right? And of course, caffeine, right, can affect the patient as well. So those are all important teaching things, right? So let's look at our anticholinergics, right? So our dry mouth, constipation, blurred vision. So of course with dry mouth, I want to provide sips of water, good oral care, assist with activity, remove environmental hazards, monitor bowel patterns and elimination, assess their vision and oral mucous membranes, teach them frequent oral care, avoid dangerous activity, and ask for help for them to stand. Anticoagulants and antiplatelet agents, right? You want to look at, of course, the biggest thing I worry about with them is bleeding, right? So we're going to minimize invasive procedures, shaving, right? What type of razor are we going to use, right? Electric razor, right? Not the ones with the blades. Provide gentle oral care. Again, nothing really, those hard toothbrushes, soft bristle toothbrushes, right? Assist with activity, monitor coagulation studies, PT, INR, hemoglobin, hematocrit, right, with our CBCs, assess for bleeding and observe for bruising. And, teaching, making sure they avoid dangerous activities that can cause them to bleed, right? Those high contact sports. Avoid shaving again with a straight edge razor. Wearing medical alert bracelets and identification. So, God forbid if they're in a car accident, then, it'll alert the EMS that they're at risk for bleeding. Again, teaching them to avoid NSAIDs, right? Alcohol and many herbs have issues and contraindications with bleeding, right? Medications, anticoagulants, right? And then like anticonvulsants, right? Central nervous system depression, myelosuppression, right? So I always think of bleeding and infection. So again, assisting them with their activity, protecting their airway, breathing, minimizing invasive procedures, monitoring their CBC, especially their WBC count, right? With differentials or neutrophils, placing them on seizure precautions, right? Assessing their temperature, changes in skin color, redness, swelling, or drainage. So those are important things too when you're studying your medications and you're noting adverse effects and side effects. Okay, what do I do as a nurse to assess for these things, right? And how do I prevent them? How do I keep them safe, right? Because remember, that's what Nclex is looking for. That's what type of critical thinking you need to develop as a nurse. So associate the class with the specific drug, right? So anticonvulsants, prototype, right? So again, hydantoins like phenytoin, dilantin, right? Barbiturates, phenobarbital, luminol. Again, miscellaneous, right? Carbazepine, tegretol, diazepam, clorazepate, valproic acid, ethosuxanimide, right? The mechanism of action of these specific drugs all treat what? Seizures, right? Anti against what? Convulsing, right? Shaking, right? Anti-seizure medications. So they treat seizures by depressing abnormal neuronal activity in the motor cortex, right? So again, associate the class with the specific drug. Adverse effects of anticonvulsants, again, sedation, drowsiness, gingival hyperplasia, diplopia, which is double vision, nystagmus, which are the eyes shaking back and forth, vertigo, dizziness, thrombocytopenia, again, looking at my platelets, my WBCs, right? Aplastic anemia, some very serious adverse effects, right? So the nursing considerations I'm going to pay attention to: advise female clients to use contraceptives, okay? Inform the client taking phenytoin that harmless urine discoloration is common. Warn clients with diabetes that the hydantoins may increase blood sugar levels and that valproic acid may produce a false positive result in urine ketones, especially if they're type 1 diabetics, right? We care about the DKA, the ketones. Teach clients receiving carbamazepine to identify symptoms of bone marrow depression, right? So of course with that, of course with bone marrow depression, they're not making what? RBCs, right? So again, issues coming up with me being able to perfuse, right, my vital organs. Reassure that barbiturates are not addictive at a low dose. They should avoid taking any of these medications with alcohol, especially the barbiturates. Administer IV phenytoin slowly to avoid cardiotoxicity and avoid mixing other drugs in the same syringe with phenytoin. So again, these are just some key nursing considerations whenever you're studying anticonvulsants. Again, these key adverse effects, nursing consideration. Is there any special teaching, anything that stands out that I should know? This is a good slide too. Helps you focus on medication administration, right? So of course we look at different things, right? Looking at the rights, right? So again, looking at the 6 rights. So right medication, documentation, route, time, patient, and dose, right? We never give a medication until we've done our rights of medication administration, right? Again, very important. Looking at the methods, right? There's topicals, right? And topicals include rectal, sublingual, nasal, eyes, ears, on the skin. There's orals, again, PO. Again, is the patient able to swallow? Follow directions. IV, right? Looking at the large bore, again, the volume. Intradermal, right? Again, just below the skin, right? Tuberculosis testing, that PPD, right? Allergy testing. There's parental, of course, sub-Q, right? So it's important that we pay attention to that. And again, there's Z-track method, right? There's inhalation, solids, transdermal, right? So all of those are important things because medication can be given so many different ways. And then you want to make sure what's your responsibility as a nurse. Administer only what you prepare. Again, if Nurse Susie prepares medication and tells you, hey, can you go give this to patient in room 123? You cannot give it. You didn't prepare it. You don't know what it is, right? So only administer what you prepare. Be familiar with the medications. Again, their general purpose. What are they used for? Their side effects, their average dose, safety precautions, adverse effects, right? And of course, you want to document the medications that you give. Evaluate the patient's condition, the medication compatibility. How are they doing with the medication? You want to always use aseptic technique. No medication, again, stored at the bedside. Review medication administration if the patient is to take medication by him or herself. So this is a nice little picture just to kind of help you focus on those key things with medication administration. So your nursing priority, right? The nurse's responsibility in administering medication is influenced by these key things. The nursing guidelines for safe medication administration, like we just talked about, and the pharmacological implications of the medications and aspects of medication administration. The nurse is legally responsible for the medications administered, even when the medication is administered according to a physician's order. So again, you'll see there's some slight variation, 5 rights, 6 rights. But again, most important rights, right? So the 5 rights of medication administration, right dose, always check medication label against the medication administration record, right? So again, patient safety, check medication label against the administration record 3 times while preparing the medication. The first time when first taking the medication out of the container, second time just before opening the medication package or pouring the dose, just before replacing the container in the storage area or giving a unit dose to the client. Right time, again, check facilities policies, usually 30 minutes before or 30 minutes after the ordered time medications can be given. Some facilities 1 hour before, 1 hour after. You always want to make sure that you're always within your facility guideline. Right route, again, check the medication order with the route that is specified. Is it PO by mouth? Is it IV, right? Is it through NG tube? Is it through PEG tube, right? Is it intradermal? All of those are important, right? Right drug, right? Proper mixing or dilution. The speed of infusion, if it's given IV push by the registered nurse. Accurate dose calculation, right? Making sure that you're checking and having another nurse check for you as well. Right client, very, very, very important, right? We could have Billy Bob John in room 2, Billy Bob John Thornton in room 5, right? Again, with the names, right? So you always want to make sure you check ID bracelet for client name and birthday, because it's not uncommon. You might have 2 John Does on the floor, right? So you need to check everything, including their date of birth, right? At least 2 identifiers, depending on the facility, again, including the barcode. So you check the ID bracelet and have the client state their full name and date of birth. If they're awake alert oriented ×3, and you verify the information with the MAR. Right, drug names. Drugs are identified by 3 names. The chemical, which is the long name, which refers to the chemical structure of the drug. For example, proponic acid. Generic is a shorter name derived from the chemical name. So generic name that we commonly know is actually ibuprofen. And then the trade name, right? The brand name assigned by the manufacturer, right? The brand name, right? The bling bling name that most people know. So the trade name is here Motrin. So of course, the biggest thing, best tip that I can tell you too for pharm, make it easier on yourself, right? Learn some drug endings, right? So again, same generic last name. The prils are your ACE inhibitors, your enalapril, lisinopril. Your sartans are your angiotensin receptor blockers, losartan, valsartan. Triptans, right? Those are for the treatment of acute migraine, like sumatriptan. Statins, right? Lower LDL cholesterol, simvastatin, rosuvastatin. Dipines, right? Again, calcium channel blockers, amlodipine, nifedipine. Your prazols, right? Your PPIs, omeprazole, protanozole, right? Your azoles, right? Your antifungals like mecanizole. Your LOLs, your OLOLs, your ALOLs, and your ILOLs, your beta blockers. But your key distinguishing factor there are your LOLs, LOL. And no, I don't mean laugh out loud, but if that's what helps you remember it, go right ahead. So controlled substances, these are drugs with abuse potential that are classified by the FDA as controlled substances. The Drug Enforcement Agency, DEA, enforces their control. Controlled substances, of course, narcotics are kept in a double locked cupboard. They used to be, right? Other controlled substances in a single locked cupboard, right? Keys to the cupboard are carried by the nurse on duty. Only authorized personnel have access to the keys. Narcotics are given only under direction of a physician or dentist. Controlled substances are accounted for on some type of record. The record includes the patient's name, physician's name, date, time, the drug, and the dose. Records are also kept when narcotics are wasted, right? This act usually needs to be witnessed and co-signed by another nurse. So again, if this was, of course, and still done, of course, in some nursing homes and rehab centers, of course, that you do what's called a narcotic count, right? Making sure we count all the narcotics that are there for the patients, right? Just to make sure we're not missing any, everything matches, right? And whenever you have a patient, say, for some reason, they said they were in pain, came back, oh, they changed their mind, and now you have to waste the medication. You want to always make sure that has to be witnessed by a nurse because they have to verify the amount and that you're actually disposing the medication and that they saw you dispose the medication. That's the whole point of having a nurse co-sign for you, right? So again, you never want to co-sign something if you didn't see it, the medication, or that they threw it away, right? You need to visibly see it. So change of shift counts are done in most facilities. Again, checking to make sure that all of the narcotics are accounted for in the right quantity and amount, because any issues with the count, of course, leads to further investigation, so on and so forth. So again, very important that you understand the rules and protocols of your facility for controlled substances. Controlled substances in the United States, 5 categories. So Schedule 1, category of drugs with high abuse potential and no medical use, generally unsafe, such as heroin, lysergic acid, diethylmide, LSD, and marijuana. Schedule 2 is high risk for abuse but also has safe and accepted uses like morphine, amphetamine, short-acting barbiturates, and cocaine. Schedule 3 are less potential for abuse or addiction than Schedule 2. So those are things like paregoric, various analgesic compounds containing like codeine, right, like our Percocets. Schedule 4 is medically useful category of drugs with less potential for abuse or addiction than, of course, the Schedule 2s as well. So a chlorohydrate, diazepam, meprobamate, phenobarbital, and then, of course, Schedule 5 is the lowest potential for abuse of all categories. So like antidiarrheals, antitussives, of course, cough medicines with opioid derivatives. So those are the controlled substances in 5 categories that they're each placed under in the United States. Pregnancy categories. All drugs are required by the FDA to be assigned to a pregnancy category of risk, meaning what is the risk to the mother and the fetus if they take this medication. And they are labeled A, B, C, D, and X. These categories indicate the actual or potential teratogenic effects on the fetus. So, of course, these are the pregnancy categories. A are controlled studies of pregnant women show no risk in first trimester. B, animal studies show no risk or animals show risk unconfirmed in humans. C, animal studies show risk, caution is advised. And then this is when it might be used if the benefits outweigh the risk to the mother and, of course, the fetus. D is evidence of risk to human fetus. Benefits may outweigh risk, and serious is a no, no, go, no, go. Risk outweighs the benefits. Right, of course. Again, as a nurse, you're always going to be given, what is prescribed as the dose, and then, of course, the administered dose, and the concentration at the sites of action for the dose that's being taken. So this really goes into, of course, those things that you learn for basic pharmacology, right? So administration, right? We look at these key things because administration is the most common thing that we see with what medication errors, right? And of course, patient compliance. Why do I have to take 3 pills a day? Why do I have to take 20 milligrams? Why do I have? So all of those things go with administration, right? Those key issues that we see. The pharmacokinetics of a medication has to do with the absorption, how it's absorbed in the body, how it's distributed, how it's broken down in the body, and then of course how it's excreted, right? Eliminated from the body, right? And usually, of course, there's 2 organs that are always involved with excretion. Drugs either come out through the liver or from the kidney, hepatic and renal. Okay, so the sources of the individual variation, again, the physiological variables, pathological variables, genetic variables, drug interactions, right? So those are things that can affect the pharmacokinetics going on with the medication, as well as the pharmacodynamics, which includes, of course, the basic, more in-depth, the patho of drugs being in the body, right? So drug receptor interaction, the patient's functional state, placebo effects, right? So that's actually medication that people think have a desired outcome, and because they believe it has a desired outcome, the outcome then can be seen as perhaps an intended effect, right? So that's an example of like a placebo effect. So it's just making sure that you understand these key steps when it comes to medication administration. So this slide, of course, just goes through the various systems and what we see with circulation, excretion, metabolism, absorption, right? So the biggest things that we focus on, of course, is with metabolism, right? So the liver, okay, the hepatic blood flow and how that works with medication, metabolism, breaking it down, excretion from the kidneys, right? So those are important things that you want to make sure that you just go over just to make sure that you have a basic concept. So first pass metabolism, this is when we, of course, nasal drug absorbs directly into the venous system. Venous system transports blood from the nose directly to the heart. The heart pumps blood out of the entire body. Of course, there's no delay. The liver, 90% of oral medication is metabolized and destroyed by the liver before it actually gets to the heart. And then, of course, portal circulation, all blood flow from the intestines is taken to the liver, of course, for detoxification, right? And oral medications sit in the stomach for about 30 to 45 minutes. So, of course, we look at all the different forms of medication, right? Capsules, pills, again, intrathecal, spinal, injections, right? Spray, could be nasal, IV, intravenous, patches, right? Lollipops, right? Form of medication, especially for children, loranges, foam, suppository. All of these are just different ways for medication to be given and absorbed in the body. So again, there's intramuscular, subcutaneous, intravenous, intrasynovial, intracardiac, intrathecal. Then there's rectal, vaginal, urethral, topical. There's eye, nasal, ear, oral, sublingual, buccal. And of course, please make sure you're familiar, of course, with these key terms, right? Because it's going to be very important on your boards. You're going to see the same thing where it pretty much, of course, asks you what are the intended effects, therapeutic effects, so on and so forth, right? So therapeutic effect is the desired primary effect for which the drug is given, right? So an ACE inhibitor is given to lower blood pressure, right? ACE inhibitor, enalapril. Remember, those are pills. A side effect, an undesirable or unpleasant client response to the pharmacotherapy, that tends to be a bit of a nuisance, right? One of the most common side effects for ACE inhibitors is actually a cough, right? Coughing at unpleasant or unwanted times. Adverse effect, of course, undesired response to pharmacotherapy that are harmful to the client or make administration of the drug very difficult or harmful. One of the biggest things we see with ACE inhibitors, I remember the A for the pril, is angioedema, swelling of the lips, right? And of course the airway. Toxic effects, of course, are dangerous or harmful adverse effects, including secondary effects, hypersensitivity, tissue and organ damage. Cumulative occurs when the drug is administered too frequently or when excretion of the drug is impaired. This may lead to adverse and toxic effects. Hypersensitivity is immunological response of the client if they have allergy and anaphylaxis, right? Like you can see with ACE inhibitors, right? The angioedema and the swelling. Tolerance, over time the drug loses its therapeutic effect, requires increased dosing to produce the same effect, and of course is not predictive of addiction. Dependence is distribution of a homeostatic function set point when an agent is stopped, leading to clinical indicators or withdrawal or psychic symptoms, right? So again, predictive of addiction. Physical, of course, is not predictive of addiction, and subtherapeutic is not reaching therapeutic effect due to low dosing, right? So medications that need to have lab values like Coumadin, levothyroxine, right? We always want to make sure that the patient is in a therapeutic range, meaning the range that's going to work for the patient depending on the dose that they're taking. So bad, 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 right? So topical, these are serious adverse effects, right? That we never want to see, unfortunately. So toxic epidermal necrolysis. So the skin is literally peeling off, right? Stevens-Johnson syndrome can occur 1 to 14 days. Do they have a cold? Okay, very serious adverse effect. Anaphylaxis is when they can't breathe. Allergic reaction, when they become very, very itchy. Again, these are really serious adverse effects, and they're one of the top fours that you always want to make sure you're looking out for. So with the oral route, there's different types of medications, right? Capsules, elixirs, powders, sprinkles, tablets. There's time release tablets or capsules, right? Extended release, so on and so forth, right? Food. Food and GI motility can affect drug absorption. Often the patient instructions include a direction to take with food or on an empty stomach. Absorption is slower with food, milk and milk products, so for tetracyclines and penicillins, right, etc. However, for medications like your beta blockers, propranolol, right, in comparison to those two antibiotics, bioavailability is higher after food, and for rhizophilin, absorption is higher after a fatty meal. So it's very important to understand that, because of course we always want to make sure that we're aware of the absorption of the medication, so that way it's therapeutic and it's having its intended effect for the patient. The oral route, of course, sometimes may have adverse reactions, right? Antibiotics may kill normal gut flora and allow overgrowth of fungal varieties. Thus, antifungal agents may be included with an antibiotic, right? Prophylactically. It's not suitable for an unconscious patient. Again, patient must be able to swallow solid dosage forms. Liquids may be given by tube. So again, we want to make sure if a patient's on aspiration precaution or they cannot swallow, we are not going to be giving medications by mouth. So of course, this also may cause irritation to gastric mucosa, nausea, and vomiting. Remember, I said GI symptoms tend to be the most common issue seen with those medications, right? So effect too slow for emergencies, right? So again, PO routes of medications, you see it takes time, of course, for absorption, metabolism. Again, sits in the stomach 30 to 45 minutes, right? So in a true emergency, where I literally only have minutes for a patient, my PO route is not what I'm going to use for an emergency. So we look at the absorption of oral drugs, right, sublingual and buccal. This avoids the first pass effect, absorbed into the highly vascularized tissue under the tongue or between the cheek and the gum. The oral mucosa bypasses the liver, rapidly absorbed. Okay, so again, that highly vascularized tissue under the tongue or between the cheeks, right? So a common drug that's given sublingual, of course, is nitro for chest pain. Common effects and interventions, again, drowsiness. So again, if there's a drug that causes drowsiness, you want to switch from day to evening dosing, of course, because they're going to sleep anyway, so you want to make sure they take it at night. You want to teach safety. Again, no driving, right? Fall precautions, right? For that patient, right? We don't want any sleepy drivers on the road, and they have to be very mindful of their surroundings to limit any injuries. Nausea, of course, if anything makes a patient have upset stomach, if they're nauseous, right, you want to tell them to take it with food or a snack. And if there's any absorption interference, right, with food particularly, you want to tell them to take it in between their meals. Again, this is a nice picture that shows you the sublingual route, right, underneath that highly vascularized area of the tongue, commonly seen, of course, with medications like nitroglycerin. Of course, this is just the anatomy and physiology of where you see the mouth, of course, just looking at the molars, right, the frenulum. Again, there's a wisdom tooth there in the back, gum, gingiva, right, the sublingual duct, sublingual gland under the mucous membrane. So these is just showing you, of course, just those markers, right? And remember, for them to be able to absorb the medication, we assess the area first. Of course, it should be, mucous membrane should be pink, moist, right? So you just always want to make sure that they're able to take the medication properly. Again, that's buccal, right, on the sides of the cheek. You can see that there, that pill going right there to the side. Buccal sublingual route. Some drugs are taken as smaller tablets, which are held in the mouth. Buccal tablet on the side of the cheek or under the tongue, which is sublingual. Buccal tablets are often harder tablets. They take about 4-hour disintegration time, and they're designed to dissolve a lot slowly. So nitroglycerin, again, as a softer sublingual tablet, it takes about 2 minutes or less to disintegrate underneath the tongue, may be used for rapid relief of angina. Hence why it's given sublingual, rapid route, 2 minutes with that chest pain. Absorption of topical drugs. So again, topical drugs avoid the first pass effect. So topical drugs include the skin, including transdermal patches, eyes and ears, the nose, the lungs through inhalation. The rectum, of course, can have a first pass effect, and then of course vaginal. So the absorption of topical drugs, many different formulations of topical drugs may be given for local or systemic effect. All have different designs for absorption, gels and ointments, erratic absorptions, lotions, patches. Absorption varies at different rates. Drops to the ears and the eyes. There's nasal sprays, suppositories, inhalers, right? So again, different formulas for different drugs. So this is the topical. Of course, you can see that patch on the skin. Dermal, usually we see as creams, ointments that just have a localized action for that particular area. Transdermal, the absorption of the drug through the skin, either systemic action, of course, getting to the body, and of course, stable blood levels, controlled drug delivery system is what's achieved when we're giving a medication through the transdermal route. There is no first pass metabolism effect, and the drug must be potent or patch becomes too large. With the mucosal membranes, such as eye drops, right, we always make sure that the eye drops are given where? In the conjunctival sac, right? So again, you always assess the eyes prior, right? Making sure that you're looking that the area is pink and moist, sclera is right, there's no issues for you to administer that medication in that area, right? So we see that too with eardrops, same thing, always assess the area before, right? Making sure that there's no pain or tenderness. Okay, to the ear, if you're able to look into the ear, assessing for any drainage, discharge, redness, erythema, right? So there's intranasal route, which is, and then there's transdermal medication, right? So this again is a nice little picture that kind of shows you the do's and don'ts with transdermal medication. Do cleanse the area of the old patch. Do remove all the old patches. I can tell you as a nurse working, I can't tell you how many times, unfortunately, I'm giving a patch and I always made sure to assess the patient, and lo and behold, there's a patch or two that was still there, right? So don't be that nurse. So always remove the old patches. Do document where you place the patch, the date, and the time, right? So the next nurse can know. Do place patch over dry skin. Do not place over dense hair, right? That's going to hurt when you take it off. Don't shave the hair, okay? Place it on a common area that you can find. Don't place heat over the patch. Take a hot bath or place over an area of inflammation, right? So again, you want to make sure that you're familiar with that. Eye drop preparations, always make sure you wash your hand, apply gloves, rinse powdery residue from the gloves off of your hands. You always instruct the client to recline, or of course put their head in a position with their head back. You have the client look up. You pull the eyelid of the affected eye down and to the side where you're giving the medication. Apply eye drop at the lower outer space of the eye. Apply mild pressure to the inner canthus for 1 minute to decrease systemic absorption, and instruct the client to close the eye gently. You wait 2 to 5 minutes before instilling the additional eye drop into the same eye, okay? So that's the same thing, and we follow that method. So if you're also giving an ointment, it's just down here, the inner and outer canthus. So you want to make sure that you're placing that ointment. Again, the tip never touches inside of the eye for bacterial purposes, right? We never touch or allow the tip of the tube or the eye drop to get to that particular patient. So with eardrops preparation, of course, always make sure the medication is warm, right? You can warm it in your hands or leave it in your pocket, right? So it could stay warm, right, as you're going to the patient's room. Ensure tightly sealed medication container. Run container under warm water. Those are things that you can do. Position client on unaffected side with affected ear facing up. Remove any drainage or cerumen with cotton tip applicator. Avoid pushing cerumen into the ear canal. You open the ear canal. Again, it's very key. In a child younger than age 3, you pull the lobe down and back. In a child older than 3 years old, you pull the pinna up and back. And then you put the drops in. You fill the dropper with medication. You hold the dropper about ½ an inch above the ear canal, and you gently squeeze the bulb on the dropper to give the prescribed number of ear drops. You instruct the client to remain in that position for 5 to 10 minutes. You repeat in the other ear if necessary after waiting 5 to 10 minutes. If the cotton balls are prescribed, place in the outermost part of the ear canal and remove in 15 minutes. With the nasal spray, you gently blow nose before administration. Of course, having the patient blow their nose, of course, same thing. Always inspect the area first, making nasal mucosa is pink and moist, assessing to see if they have any deviated septum, and of course, checking for patency. Okay, so again, gently have the patient blow their nose, shake the container, have them tilt their head back slightly, occlude one nostril, insert spray tip into the other nostril, activate the spray, and gently have the patient inhale through that nostril. Okay, very straightforward. Route, most commonly by suppositories or enema. The key advantage are it bypasses the liver, so some of the veins draining the rectum lead directly to the general circulation, thus bypassing the liver, reducing that first pass effect. It's useful for patients unable to take drugs orally, right? Like particularly to unconscious patients or with very young children, right? And especially too, it's a good route if the patient is nauseous or vomiting. Rectal route disadvantage are erratic absorption. Absorption is often incomplete and erratic, okay? And it's not well accepted. So again, it's one of those things you kind of weigh out the risk, benefits, and the probabilities. So again, based on those populations is when we see them the most. Suppositories, of course, you always want to make sure you're using standard precaution, wear your gloves, do your hand hygiene. Okay, remove foil wrapper and lubricate the suppository if necessary. If used for systemic indication, have the client defecate if possible to allow facilitation of the medication. Position client on left lateral position and insert just beyond internal sphincter. Instruct the client to retain the medication for about 20 to 30 minutes for stimulation of defecation and 60 minutes for, of course, systemic absorption. Inhalation route. You want to make sure, of course, if you're using an inhaler without a spacer, of course, this is just with one puff using the meter dose inhaler. So you want to tell the patient, shake the canister for about 2 to 5 seconds. Hold the meter dose inhaler with their thumb under the mouthpiece and the index and middle fingers on the top of the container. You position the mouthpiece, and then the client has two options. The first option is to place the mouthpiece of the meter dose inhaler in their mouth without opening or pointing towards the back of the head. The client tightens their lips around the mouthpiece, so that's option 1. Option 2 is having the patient position the meter dose inhaler 1 to 2 inches in front of their open mouth, pointing, of course, toward the back of the head, and the lips should not touch the mouthpiece. Then you have the patient inhale deeply and exhale completely. They tilt their head back slightly and simultaneously inhale slowly and deeply through their mouth while depressing the canister, pressing down on it. They continue to inhale slowly for 2 to 5 seconds, then hold their breath for 10 seconds. Very important that you know how to teach this technique. Common Nclex question, common drag and drop question. So of course the technique with a spacer, you insert mouthpiece of the MDI into the spacer. Of course, still have to shake the canister for 2 to 5 seconds. You insert the mouthpiece or spacer device into the mouth, being careful not to cover the escalation vents on the spacer. They want to tell the patient to breathe normally through spacer, depress the canister, spraying one puff into the spacer. You have the patient inhale slowly and fully for 5 seconds. You have the patient hold their breath for 10 seconds. You have them rinse their mouth after using the MDI with or without the spacer. And then, of course, you have them wait 20 to 30 seconds between puffs before administering second puff or additionally with additional medication with the MDI. And then, of course, you want to divide the number of doses into the container by the amount of doses used per day in order to determine how long the MDI will last. With the inhalation route, the biggest thing are some of the disadvantages, right? So, of course, most addictive route of administration because it hits the brain so quickly. So that's one of the drawbacks to that. Difficult in regulating the exact amount of the doses, again, because of the spray amount. And sometimes the patients have difficulties in giving themselves a drug by inhaler. So again, those are some of the factors that we really want to consider. Again, this is just a picture of the patient there using that inhaler. This, of course, is the inhalers that we see with a spacer that can be used. And then, of course, that's common there. That just delivers one dose. That's commonly seen with patients who have asthma. And this gives you, of course, another instruction on how to use the meter dose inhaler. Again, having the patient check the medication, how long, and making sure that you're familiar with this slide as well. This is just for my visual learners. If that helps you, make sure, because it's very important. And the best way to make sure that you know how to teach a patient to use a meter dose inhaler is teach back, right? So take time just to talk it out, right? Teach it to somebody, teach it to your stuffed animal, teach it to your husband, your wife, the dog, whoever will listen, right? And make sure, because this is a very important item that usually shows up on boards. This shows you, of course, how to use a nebulizer. So, of course, with the nebulizer, you put the medication into the medication cup. You attach the mouthpiece or mask to the medication cup. You attach the medicine cup to the compressor tubing, and then the patient places the mouthpiece in their mouth, and of course, or place the face mask over their nose and mouth. They have to breathe through their mouth until all of the medication is gone. So there's nothing else left in the medicine cup. So drugs are intravenous. This is the fastest delivery into the blood circulatory system. There's IM and there's sub-Q. Parenteral drugs also include intrathecal, intra-articular, intradermal, and transdermal can also be considered parenteral too, so it kind of has a dual effect and purpose. So, of course, the absorption of parenteral drugs, we look at, of course, parenteral drugs have no first pass effect, right? So intravenous is rapid and 100% bioavailable. It's our preferred route in an emergency, avoids problems with the stomach acid and intestinal absorption issues. IM are not as rapid as IV, but they will absorb better if there's like really a good blood supply in a highly vascularized area. And just remember, some IM injections are in depot form, right? So a depot injection is a slow release form of medication. The injection uses a liquid that releases the medication slowly so that it can last a lot longer. So these depot injections can be used for various types of drugs. A lot of times we see them with antipsychotics. So, of course, these are important because the absorption time can last sometimes even months, right? Due to the formulation of these drugs, they should never be given IV, right? And they can actually cause an embolus as one of the adverse effects. So, just important to note. Of course, it's very important for you to know, of course, the different gauges, right? The lengths, different colors. Again, it's always going to vary by state. And of course, making sure that you're familiar with what your facility uses, right? So again, making sure that you understand the colors, the gauges, right? So an 18 gauge, of course, is 1.2 mm's, right? And so we just look at those things to make sure that we're familiar. 22 gauge, 18, 20, again, vary by institution, but again, the color code usually tells you the gauge length. So we're looking at the parental routes, right? Continuous, so subcutaneous, right? Underneath the skin. Common medication that we give, of course, subcutaneous is insulin, and we're going to talk about the insulin. Very important for boards, right? Intradermal is into the skin itself, so that's used for skin testing, especially with allergens. Intrathecal is into the spinal canal, right? Most commonly seen for spinal anesthesia, like epidurals. And then intraperitoneal is actually infusion or injection into the peritoneal cavity in the abdomen, right? So like peritoneal dialysis in the case of renal insufficiency, right? Intradermal, ID, allergy sage, subcutaneous, some common ones we see, insulin, heparin, vaccines. Intramuscular, of course, a lot of times with pain medications, anti-infectives. Intravenous, IV, directly into the bloodstream. At intradermal and subcutaneous, again, it's really about the area that it's going underneath the skin, right? So the intradermal, again, is just below that skin, really between that epidermis and dermis layer. Subcutaneous goes a bit further, of course, into that dermal layer, right before we hit that subcutaneous tissue, right? And of course, making sure that we pay attention to the angles. So especially with the sub-Q, you always want to make sure that you're doing it at a 45-degree angle. And then with the intradermal, just barely creating that skin, sometimes between an 8 to 10 angle that you want to make sure that you get. For inserting injections, of course, I am straight shot, 90 degrees, subcutaneous, 45. Intravenous is at about 25 degrees, and intradermal ranges between, of course, 10 to 15. So you always want to make sure that you're holding the needle appropriately and accordingly, right? So again, a lot of those memes, of course, nurses give the shots, right? Be careful, I jab. So this is why. The intradermal, it has a slower absorption rate. Administration used in the tuberculin syringe, what we commonly see to create that wheel when you're, of course, we're taking that infamous PPD when the doctor ordered a Mantoux test, right? So the needle is between a 25 to 27 gauge. The length is about a quarter of an inch to half an inch. The dose is usually 0.1 to 0.01 mLs. And then, of course, the angle is always between 10 to 15 degrees from the skin to deposit the medication below the epidermis, forming that wheel underneath the skin. So that's what we commonly see, of course, with the intradermal when we're doing the Mantoux test and injecting purified protein derivative to see if the person has been exposed. Of course, with subcutaneous, this implants and injections, of course, it's a parental route of administration of medication into the loose tissue between the skin and the muscle. So the medication must not enter the muscle, right? So, of course, we use a sub-Q needle, right? 5 to 8-inch needle greater than a 21 gauge. Insulin syringes come in many smaller sizes, depending on what they're going to use there, 5/16 of an inch or 8 millimeters, so on and so forth, right? And of course, we use 45 degrees or a 90-degree angle, but the preferable degrees, of course, is going to be 45. Aspiration not required. Do not massage the injection site when you're giving a subcutaneous injection, and you always want to do a big teaching on rotating the site, right? So that they don't have issues with lipodystrophy, and you always document what site you last gave it, right? Big part of education, and for yourself, always rotate sites. And this is just a nice picture that helps you visualize, again, how deep the needles actually go through the dermal and transcutaneous layers, right? So there's intradermal, subcutaneous, and IM, okay? Good visual for you to understand. Intramuscular, of course, four most common sites include the ventral gluteal, dorsal gluteal, vastus lateralis, and of course the deltoid, right? Absorption is affected by the muscle's perfusion, fat content, and degree of vasoconstriction. The administration, of course, is the need to aspirate, right? Inject medication into large muscles, avoid soft tissue other than muscle, especially nerves and vessels. The needle angle is perpendicular 90 degrees to the tissue being injected. Usually children younger than 18 months, we're always going to use the vastus lateralis muscles, those thick thighs, those chunky, cute little thick thighs, right? Older than 18 months, use the vastus lateralis, ventral gluteoid, or the deltoid, right? And inject up to 2 mLs for children. The deltoid should be limited to about half an ml or an ml. So if you're going to use the deltoid, be mindful of the amount that you're drawing up. So of course, these are the needle lengths for injections, right? For infants 0 to 12 months, we use a 5/8 inch. Toddlers and preschoolers, 5/8 inch to an inch. Toddler age and adolescent, 5/8 inch to 1.5 inches. Adults, we're really staying between 1 to 1.5 inches. Older adult or debilitated adults, we use 5/8 to about an inch. Okay, and we always make sure that we're familiar with our landmarks for injection. So with the ventral gluteal muscle, we place the index finger of our non-dominant hand on the anterior superior iliac spine, right? That iliac crest, upper outer area of the buttocks, right? We form a V, right, with the index finger and the middle finger. Aim opening of the V laterally. Okay, so the middle finger is pointed towards the iliac crest, and that index finger is pointed toward the anterior superior iliac spine. Then the injection site is between the index finger and the middle finger, creating the area for you to give the injection, right? And of course, this makes sure that you have and minimize the risk for any injury when you're giving that IM injection. So this is that ventral gluteal injection I was talking about, right, with the anterior iliac spine, the iliac crest, using your index and middle finger as your landmark points, and then of course that greater trochanter that you see there from the hip area. So again, right in between where you see that injection site is with the red little circle, bullseye. This just gives you a great visual again on the intramuscular. You see how long those needles are, right? Subcutaneous and of course intravenous. So again, this gives you a great one-on-one look at an IM injection going straightly 90 degrees straight in into the muscle. This gives you a look, of course, of being able to give a subcutaneous injection, okay? Either at the 90 degrees, you'll use a 3/8 inch needle, and of course, if you're giving it at a 45, again, preferably in a 1/2 inch needle. Again, especially with an insulin syringe, you want to make sure that you're doing it appropriately. These, of course, are the critical landmarks, of course, that we can give subcutaneous injections bilaterally, right? So the abdomen, the thighs, and of course, the deltoid area. So you always want to make sure you're familiar with these sites, and can be seen as hotspot questions on exams as well. And you always want to make sure that the patient rotates sites. So if they use their left abdomen today, they might want to use the right abdomen tomorrow, use the left thigh Wednesday, so on and so forth. The parental route, of course, intramuscular is into the skeletal muscle. Okay, the advantages is suitable for injection of a drugs in aqueous solution, rapid action, and in drug suspension or emulsion, which are like sustained release medications at a set dose over time. Biggest disadvantage, of course, did you see how long those needles were, is pain at the injection site, especially for certain medications. Okay, so these are some of the sites there where you can really see the musculature, again, putting it into a highly, where there's good blood supply, right, to maximize absorption. Of course, this shows you the outer upright quadrant of the injections that we can give, of course, and the different areas, of course, making sure that we never hit that sciatic nerve for the patients. Okay, that's for the babies, right? The site that we're going to be using. Again, this just gives a good anatomical look at the deep femoral arteries, the sciatic nerve, the rectus femoris, the vastus lateralis, of course, is the muscle that we're aiming for, and the femoral arteries and vein. Very important that you know your anatomy and physiology, because we want to make sure that we are never hitting the area other than that vastus lateralis muscle. Injections include, of course, giving some medications using the Z-track method, and the administration of these particular medications, because these parental medications can likely harm or irritate the tissue, so that's why you want to use this special technique. So the first thing you're going to do after drawing up the appropriate amount of medication, say 0.5 mLs, is to add 0.2 mLs airlock, change the needle to ensure the medication is not tracked into the subcutaneous tissue during needle insertion. Select a large deep muscle, IG, the ventrogluteal, for example, pull the skin slightly down or laterally before injecting. And then, of course, inject the medication and continue to hold the tissue in position. You allow the needle to remain in place for about 10 seconds after the injection. Then you immediately withdraw the medication and quickly release the skin so that the layers of tissues move over the needle drag to seal the medication in place like a Z. Okay, that's really where it got its name from. Again, this gives you that picture of like where you're displacing that skin, moving it over, putting the medication. As soon as you pull that needle out, boom, the skin goes right back, creating that seal for that medication. So there are special types of IM injections. Again, the depot injection is the one I explained, right? So again, with those, that may result in gradual release of the medication over extended period of time, several days to weeks to months, right? So of course, an example is Samudabine depot. It's used to treat acromegaly, and Copaxil depot used to treat schizophrenia. So again, making sure that we know that it takes a longer time, of course, gradual release of the medication, it doesn't work right away, right? So we want to make sure that we're familiar with the IM injection technique, right? Going in at 90 degrees, our angle, our landmarks, and using that Z-track method if indicated. Right, intravascular is IV and IA, right? So placing the drug directly into the bloodstream, maybe intravenous into a vein or intraarterial into an artery. The advantage are it's precise, right? Accurate and immediate onset of action, 100% available in the system, bioavailability. The risk of embolism is high, and then high concentrations attained rapidly can lead to greater risk of adverse effects because of the 100% bioavailability. So of course, that shows you IV, intravenous, right? So this is how you can give medications, right? Once that catheter is inserted, medications and fluid can be given through that catheter. It's very important when we're looking at other means. Of course, we'll talk about them in a little bit, but of course, PICC lines, central lines, ports for administering chemotherapy. Again, various reasons, indications for them delivering precise medications. So again, these have to be inserted by a medical doctor, sometimes the PA, specially trained nurse practitioners. Again, these are not things that nurses are inserting, but again, there are special, as the exception would be the PICC line, where you can have a PICC line nurse who's been adequately trained and is pretty much just, that's their job, is to insert the peripheral inserted central catheters, right? So those are important things to know. So this pretty much shows you, of course, just the routes there of the subclavian vein, the different areas, different veins that they can use when they're doing like central lines. Well, this is a non-tunneled central venous access device that's inserted, of course, into the patient. You can see the catheter tail, the cap, the exit side out of the skin, the vein entry, collarbone, and it goes directly, of course, to the heart. As part of the tunneled central venous catheter device, part of the catheter is encased in subcutaneous tunnel, right? So the tissue actually granulates onto the cuff surrounding the catheter, creating a good barrier and an anchor for it. It's inserted surgically through the subclavian vein. It's useful for frequent long-term IV therapy. And of course, typically no dressing is required after the cuff heals. And there's different types, Broviac, Hickman, Grosjean. So again, depending on what was inserted and the type of catheter. This is a picture from the previous picture, but we're actually seeing it in an actual patient, right? Again, delivering long-term IV medication. So the implanted port is surgically implanted, then septum with reservoir and attached catheter. Can be painful. Needle insertion, like the Huber non-core needle, must be used to access the port. So again, it has to be accessed, and a nurse has to be trained in order to do that, right? So you need that special certification. They must always confirm needle placement before medication administration, and it requires flushing after each use, right? All of these ports, but again, whenever you're using anything that involves going into the vein, you want to always make sure you're flushing before and after with 10 cc's minimum, right? So it requires After each unused port is flushed monthly, and of course, it's usually flushed again with a heparin solution just to make sure that there's no clot formation going on and that the medication can be delivered freely and accurately. And this just shows you the picture of the port being accessed for a patient, again with the needle, and then how it goes directly into the venous system. This just shows you the picture of a port directly implanted into an actual patient, okay, that can be used for chemotherapy. It's a really great slide made for you just to go through again the non-tunneled catheter, peripherally inserted catheter, the PICC line, the tunneled catheter, and the implanted port, right? So the insertion techniques, and then of course the dressing changes are sterile for the first three and not required for the last one. Okay, and then you want to look at the different users, the unique features there. So you want to make sure that you're familiar with this slide. Are infused to maintain fluid balance, replace fluid losses, or treat electrolyte imbalances. So that's really important because we're going to look at the common IV solutions and their names, right? So there's isotonic, hypotonic, and hypertonic, right? So of course, isotonic can be in dextrose in water, or of course, our fluids can be in saline. So it's very important for us to make sure that we know the difference. So we're going to look at, of course, dextrose and saline, and of course, electrolyte solutions. Isotonic solutions have an approximate electrolyte count and content of 300 milliequivalents per liter. This type of solution is infused to replace fluid losses, usually extracellular losses, and to expand the intravascular volume. Hypotonic solutions have an electrolyte content of less than 250 milliequivalents per liter and are administered to expand the intracellular space. They are commonly infused to dilute extracellular fluid and rehydrate the cells of patients who have hypertonic fluid imbalances and to treat gastric fluid loss and dehydration from excessive diuresis. Again, getting the cells hydrated once again with hypotonic solutions. Solutions with electrolyte content of 375 milliequivalents per liter or more are considered hypertonic. Hypertonic solutions are infused to treat patients who have severe hyponatremia. Depending on the type of hypertonic fluid infused, it can provide patients with calories, free water, and some electrolytes. Examples of hypertonic solutions are dextrose 10% in water, D10W, and dextrose 5% in sodium chloride. Phenomenal IV solutions cheat sheet, going over again the normal saline, half normal saline, lactated ringers, okay, D5W, D5W normal saline, D5W and a half. Again, it's here for you to review. Uh, Basic knowledge for nurses, knowing what fluids to use, when to use them. A lot of times there's standing orders for them. So you just want to make sure that you're familiarize yourself with them. Again, like I talked about, going over each one by one. So again, you might want to put these on note cards, go through them, make sure you really understand them and their uses and contraindications that they might have. Of course, looking at this, you see that isotonic solutions, again, maintain that homeostasis, of course, between the cell and the outer environment. Hypertonic solutions, of course, is usually for that extra cellular space, and hypo, of course, is intracellular. So you really get a visual with the types of fluids and their movement of the vascular space, intracellular space, and extracellular space. So again, this just shows the solutions in relation to normal red blood cells. So again, isotonic solutions, keep that solution, everything going in and out, and the solutes in a normal isotonic stable way. Hypotonic, of course, is to make sure that the cells get rehydrated, and hyper, of course, is more concentrated solute solution where the water, the excess fluid is actually leaving the intracellular space. And I always remembered hypo, hippo, right? And hyper, we hype when we outside, there's more people at the party. Your good visuals of the fluids, and of course, fluids are always placed on IV pumps. There's direct administration of opioids and local anesthetic agents into the epidural space or the intrathecal space. The benefits: lower systemic side effects, lower dosing of therapeutic agents, and then, of course, dose-dependent effects: itching, nausea, vomiting, respiratory depression, urinary retention, and the biggest adverse effects, of course, are delays, respiratory depression, and having those biggest issues with the airway. Here you can see spinal column, and then of course the catheter that's being inserted into the spinal column, and then the push insert it in under the skin, the pump that's inserted under the skin as well. So intraosseous, of course, is into the bone. Percutaneous placement of intravenous catheter into a marrow cavity, used when peripheral vessels are collapsed or inaccessible. Again, critical situations, trauma, they'll go straight into the bone. Metabolism biotransformation is a capability of the liver to metabolize drugs, um, and that varies widely between patients, right? So we look at different factors: age, genetics, foods, concurrent use of other medications, diseases, right? So again, the elderly have decreased hepatic enzymes, neonates have immature liver functions, right? Genetics, of course, plays a key role in seeing what drugs can be metabolized and are usually metabolized at different rates if there's a genetics predisposition to a certain group. Foods like grapefruit and certain other foods may affect metabolism: grapefruit, orange juice, herbs, things of that nature. And then use of other medication, again, Tylenol, many other drugs. So again, we always look at what drugs are taken with what and acids. And then, of course, diseases: cardiovascular or renal dysfunction, right? If they're in end-stage heart failure, or if they're in acute kidney failure, if they're on dialysis, all of those play a role in biotransformation and metabolism. Excretion. So the kidneys are the main organs, right? And help with the elimination of drugs from the body. That's what excretion really is, right? So whether the drug is an original compound, parent compound, or an active or inactive metabolite, that's how it's usually excreted from the body. Again, the liver and bowel can help with some excretion, biliary excretion, enterohepatic circulation, but for the most part, it's the kidneys that carry that weight of excreting from the body. About 80% of drugs are excreted from the body from the kidneys. So excretion: the kidneys remove the drugs that are unbound free in the plasma, and certain drugs, like highly protein-bound drugs, can't be excreted and are reabsorbed back into the system. So excretion: patients with renal failure will not be able to excrete drugs effectively. Drug levels, of course, will increase because of this, and the patients may experience more adverse effects and toxicity. So with this, we look at the pharmacotherapeutics, right? The therapeutic drug monitoring. So certain drugs need close monitoring of blood levels during administration. They have a potential to become toxic, right? So can become toxic at very low blood levels. With the therapeutic drug monitoring, the goal is to have enough drugs in the body to get the positive desired effect without producing undesirable adverse effects of toxicity. If the peak is too high, organ damage may result. If the trough is too low, the drug may not be at therapeutic levels. So that's why it's so important to look at those key things. So, of course, some drugs have a very narrow range between their therapeutic and their toxic levels. So that's why it's so important to really know and making sure that you're checking those lab values before you give those drugs. You may need to hold them, right? So digoxin, that key heart medication, and gentamicin, antibiotics, right? The myosin groups are examples of common drugs that need to be monitored with blood levels. In therapeutic drug monitoring, the peak is the highest blood level, the trough is the lowest blood level, right? So the blood is drawn at specific times before and after drug administration. So the amount of the drug in the body guides the pharmacist in adjustment of the drug dosages and also guides the provider, right? So if it's an infectious disease doctor and they're providing vancomycin to the patient, they need to know the peak and the trough because they're going to adjust the dose accordingly to the blood levels and what they're seeing in the patient. Visualization of the peak and the trough, right? So again, we have that therapeutic level that we want to maintain with that initial dose of antibiotic. It's going to go to the peak. So the peak is 30 minutes to an hour after the administration. So we're looking at that therapeutic level. So that's high enough. We're getting close to toxic. And then the trough is 30 minutes before the next dose of medication. So that's when they're taken, right? So the peak is taken 30 minutes after, 30 minutes to an hour after the medication was administered. So if the Venco was administered at 9:30, we take it at about 10 or 10:30, right, to see exactly how potent that medication is. And then, of course, the trough is 30 minutes before the next dose. So if the next dose is scheduled at 2 p.m., we would take the trough at 1:30, right? So those are important things to know, the peak and the trough. To know these key things: onset, peak, and duration, and trough. Onset is the time it takes for the drug to elicit a therapeutic response. Onset. Start working in the body. So the peak, of course, is the point in time after administration when a medication exerts its strongest therapeutic and adverse effects. A serum blood sample is drawn about 1 hour after the drug is administered. When is the peak effect? Of course, it's a good time for a dressing change or other painful procedure. Again, the peak is when the drug is most what? Potent. Peak equals potency, right? Strongest therapeutic effect. So if you're giving a medication such as morphine, dilaudid, right? When that medication is peaking is when you want to do things like a dressing change or a painful procedure, because that's when, of course, it's going to have the most powerful analgesic effect, right? To lower the patient's pain. Is the time a drug concentration is sufficient to elicit a therapeutic response, right? So basically, how long is it going to last, right? So again, in between the doses, right? So how long is this pain medication going to last? How long is this blood pressure going to last? So that's why it's so important to know how long it's going to last, because that'll tell you, of course, different things about the next dose, if it once a day, QPRN, all of those key things. Again, the trough is the lowest blood level of a drug, right? Serum blood is drawn about 30 minutes before the next dose is going to be given, right? Before a medication administration. Always remember the trough. So again, if you have that medication scheduled for 1400, you're going to be getting that trough at 1330. So again, these are key things you want to remember even as you practice as a nurse. You might want to put a reminder, write it on your clipboard for that particular patient, right? Highlight it. Very, very important. And make sure, of course, it's in the computer system and it's ordered so lab can come draw the labs for you. It takes for 1/2 of the original amount of a drug in the body to be removed. Of course, it's a measure of the rate at which drugs are removed from the body. Most drugs are considered to be effectively removed after about 5 half-lives. Pharmacodynamics, right? So these looks at the receptor interactions, right? So agonist, right? Drugs that fit well at the receptor site and elicit their own response. Agonists are a drug that binds to a receptor of a cell and triggers a response by the cell. The agonist, of course, mimics the action of the naturally occurring substance. Antagonists, drugs that affects to the receptor, so they attach the receptor site and block other drugs from attaching there, right? Antagonist, right? So sometimes we think of the antagonist as quote unquote the villain, right? The bad guy, right? So when a drug binds to a receptor and blocks itself from responding, it also prevents the agonist from binding to that receptor. Interaction. So both agonists and antagonists are used in drug therapy, right, for their effects. So example, albuterol inhalers for asthma is an example of an agonist medication, something that occurs naturally that I wanted to do, right? Benadryl, diphenhydramine is actually an antagonist, right? Preventing histamine release. So with the pharmacotherapeutics, right? Acute therapy, right? So we need acute therapy for key things, right? Like stroke, heart attack, right? Because remember, tissue is time. Time is tissue, right? So again, with a stroke, the brain is dying. With a heart attack, the heart is dying. Maintenance therapy, of course, maintenance, maintaining that blood pressure in the right range, right? So hypertension, high cholesterol, hyperlipidemia. Supplemental replacement therapy, of course, like insulin, iron, thyroid hormone. We're replacing, meaning my body is not making it or I don't have enough of it, right? A palliative therapy, right? So that's when we look at, again, palliative, right? Creating that atmosphere for the patient to be comfortable, right? So high dose opioids for cancer patients, supportive therapy like fluid and electrolytes, volume expanders, pretty much just maintaining other attributes of my vascular system, right? Prophylactic therapy, right? Antibiotics before surgery to prevent an infection, right? Pretty much anticipating and preventing something or reducing the risk of something is prophylactic therapy. Empiric therapy, right? So experience shows it works. There's no evidence for it, but experience shows it works. So this, of course, shows the TPN solution, right? Of course, how it goes in, the subclavian vein, the filter, the right inomat vein, the superior vena cava, the catheter, and of course, that's an example of TPN solution mixed with whatever the doctor orders, vitamins, protein, so on and so forth. Of course, TPN provides nutritional support for nutritional so clinical indications for hyperalimentation includes client who cannot use GI tract for absorption of nutrients, requires nutritional therapy to maintain or improve their nutritional status, and of course have high risk for malnutrition. Hyperalimentation solution contains hypertonic dextrose and amino acid solution, right? In high concentrations, usually the highest is 25 to 35% dextrose. That's a lot of sugar, right? Gives you the white bag there, right? That's TPN, and it's always prepared in the pharmacy. So the biggest things you want to prevent complication when it comes to TPN, total parental nutrition, right? So again, with all that high concentration of dextrose, you want to make sure again that they don't get any rebound hypoglycemia. So that's why TPN has to be withdrawn slowly, okay, tapered down. Hyperglycemia. So again, usually when they're on TPN, because of that high concentration of dextrose, 25 to 35%, you need to make sure they have coverage, right? So you verify insulin coverage, check their blood sugars frequently. And sometimes they're at risk for acidosis, right? So you want to maintain that tight glycemic control, encourage coughing and deep breathing, right? Minimize the risk for infection. Remember, high concentration of sugar, just like with diabetics, risk for infection increases, right? So we also want to make sure that we're assessing fluid shifts, hypervolemia, and osmotic diuresis, right? So you usually give about 10% dextrose if TPN infusion is interrupted. Carefully control infusion rate. Carefully program the infusion device. And we always check because of where it was inserted. You guys saw on the previous slides, above that subclavian vein, they can be at risk for air emboli, right? So you always use a lower lock connector, right? You cover the site with an occlusive dressing, a 3-sided dressing, making sure to inspect it for any signs of infection, redness, edema, right? Any discharge, approximation, right? And you may need to position the client in supine position or ask the client to perform the Valsalva maneuver, right? In that case of an emergency, and clamp the tubing when changing the solution, right? Or the tubing that we see with total parental nutrition, hyperglycemia. So most solutions contain insulin or client on sliding scale, insulin regardless of history of diabetes. The infection solution provides breeding ground for microorganisms and fluid imbalance. So you have to make sure that you stay on top of it. So lab work, we look at the blood urea nitrogen, creatinine, liver function test, pH, glucose monitoring, frequent checks, right? Minimum once a shift due to impairment of glucose metabolism. We look at serum electrolytes, glucose, cholesterol, triglycerides, labs with TPN. The blood types, right? Each person has one of the following blood types, either B, AB, or O. O can be given to anyone, but can only receive O. Remember, they're the universal what? Donors. AB can receive any type, but can only be given to AB. Again, universal recipients, right? So also every person's blood is either Rh positive or Rh negative. Very important for you to know, because when you get into OB, you need to know what that mom is and what that dad is, right? Rh negative or Rh positive. The blood is used in transfusion must be compatible with the patient's blood, right? So type O blood is called the universal donor. People with type AB are called the universal recipients because they can get, of course, from A, B, and O. O can give to everyone, to A, to B, and to AB, right? So people with Rh positive blood can get Rh positive or Rh negative blood, but people with Rh negative blood should only get Rh negative blood. Key things for you to remember here. So of course, this just shows you, of course, the percentage, the always positive, A positive, B positive, A, B positive, O negative, A negative, B negative, AB negative, right? In relation to, of course, the percentage in the population. Again, plasma is the liquid part of the blood, a dilute solution of salts, glucose, amino acids, vitamins, urea, proteins, and fats. White blood cells, of course, are involved in the immune system, and of course, platelets are involved in blood clotting. Red blood cells are involved in carrying oxygen. So, of course, plasma, of course, is what's taken from the blood, right? So this is a good look at, when we draw blood, what are we looking at, right? So it shows you by weight, concentration, how it's broken down, what we see. So very interesting. So when they're getting those vials of blood, this is what the lab is pulling, and this is how it's concentrated in the body. So just remember, with Jehovah's Witnesses, right? Basic position on blood. They will not accept whole blood, red cells, white cells, plasma, or platelets. Personal decision will be coming down to, again, if they can get red cell fractions, hemoglobin-based blood substitutes, right? White cell fractions, which are pretty much interferons, interleukins, plasma factors, which has albumin, globulins, clotting factors, and platelet fractions, which have wound healing factor, right? So again, that's the Jehovah's Witnesses, and again, everybody else, it's a personal decision whether they'll accept it or not. Again, this shows again blood that's taken, right? Looking at the plasma, the formed elements, and how it's dissected plasma by percentage, right? Of water, formed elements there, and then albumin, globulins, fibrinogen, proteins, ions, nutrients, waste, gases, and then of course the WBC bands, neutrophils, lymphocytes, monocytes, eosinophils, basophils. So of course this shows you the whole blood, plasma, and the formed elements. Course, this is very important for you to know. Bone marrow, right? So this is where all the magic happens, right? So our red blood cells, white blood cells, platelets, all are formed from where? Bone marrow, right? So again, very important for us to know. Now the red blood cells are vital, right, to our what? Oxygen carrying capacity. White blood cells are for what? Infection, and then it has a whole team, right? So the lymphocytes, monocytes, eosinophils that mount an allergic reaction, basophils, neutrophils, right, for an infection, and platelets are important for what? Clotting. So again, whole blood, right, for severe blood loss, right? Red blood cells for surgical and trauma patients, as well as patients with anemia, such as dialysis patients. Red cells can be stored and refrigerated for 42 days. White cells are given to help fight infection. Platelets are, of course, to control bleeding. They are given to treat leukemia patients and cancer patients who are undergoing chemotherapy, right? Platelets only last 5 days. Plasma are used to treat victims of burn, shock, or severe dehydration. It can be frozen and stirred for actually up to 1 year. Cryoprecipitate is used to treat patients with coagulation problems. So again, depending on what's going on, we need to know what to give them and what's going to be ordered. So of course, this shows you the red blood cell types, right? Group A, B, AB, group O, and the antibodies that are present, depending on what will form when they receive certain kinds of blood. So again, this is just a little list here where you see the diet profile, what's allowed, what's not allowed, foods to avoid for weight loss purposes, depending on the blood type, okay? 8 rights of transfusion administration, right? So this is very critically important, right? Especially for the registered nurses, right? Registered nurses give the blood, licensed vocational lawyers do not give blood. So again, right product, patient, dose, the time, the reason, the site, documentation, and of course the response. So the blood bag identification number, we're checking that. We're checking the expiration date. We're checking what type it is. Is it A, ABO? The RH type should be on there as well, right? And blood is always hang with what type of tubing? Y tubing. It comes with a filter, a drip chamber, right? And a roller clamp. And the only solution that blood can ever be given with is what? Normal saline, normal saline, normal saline, right? So this is the setup for blood transfusion. You need a second nurse to make sure that you check all of those things there. Again, the blood bag identification number, expiration date, blood type, the numbers, everything has to match. It's critical. Again, this is a patient getting a blood transfusion into a peripheral IV catheter. This is an actual picture of the blood hanging, being transfused into the patient. So guidelines for administration, sign consent forms required for blood administration, retrieve the blood from the blood bank area. Together with another RN, you compare the blood and the cross-match slip from the blood bank and compare data with the client's ID bracelet. You verify that client's name, ID number, blood type, and RH factors. Donor number on the blood container and expiration date. You establish baseline data and monitor. So you follow agency policy for frequency and duration. Those vital signs are pivotal, right? So I'm checking the O2 sat, checking the skin for the first 15 minutes of the transfusion, right? Heart rate, respirations, blood pressure, okay? During administration, as per policy, and 1 hour post-transfusion. Always assessing before, during, and after breath sounds, crackles, dyspnea, jugular vein distension, anything that can be indicative of acute reaction or that the patient is in distress. So we're always checking these key labs: hemoglobin and hematocrit, urine output, serum potassium, calcium, and creatinine. Prime IV infusion tubing with normal saline for whole blood administration. Never use dextrose solutions under any circumstances because this may cause clumping of the red blood cells, and ensure that the insertion site is patent and it flushes. You initiate the transfusion slowly for 15 to 20 minutes, and you always stay with them those first 20 minutes at the bedside minimum. You question the client about any unusual feelings that we're going to talk about. You monitor vital signs every 5 minutes or follow agency policy. Again, general benign hives may occur, but you still want to monitor the patient for any signs and symptoms of an anaphylactic reaction. You return the transfusion record to the blood bank when the infusion is complete. Okay? Most reactions are due to human error and occur within the first 15 minutes of a transfusion. So that first 15 minutes is a critical point for you and the patient. Blood products, RBCs, right? Washed RBCs are RBCs washed with sterile saline before administration. It removes some immunoglobulins and some protein. Packed RBCs are blood cells that are separated from plasma and platelets and decrease the risk of fluid overload. And then, of course, autologous blood transfusion is blood that the patient stores for their own self. If they're going to surgery, they can have their blood for their own use, right? Auto means self. Right, leukocyte poor RBCs are removal of leukocytes, fewer RBCs, and packed red blood cells. Reaction, most common type of reaction, right? Findings are usually hives and itching. So these may be treated with antihistamines, diphenhydramine, of course, Benadryl. Febrile reactions are reactions to the white blood cells in the donated blood, more commonly seen in clients who have had previous transfusions and in multiparal women. Usually with this, you'll see fever within 24 hours of the transfusion, including headache, nausea, chills, or general feeling of discomfort. This also may be treated with antipyretics like acetaminophen, Tylenol. Reactions usually, of course, can have different causes, right? So hemolytic reaction is incompatibility between the client's blood and the donor's blood. So the patient will usually show up with chills, fever, headache, backache, dyspnea, cyanosis, chest pain, tachycardia, and low blood pressure. So for this, you want to discontinue the IV fusion immediately without a doubt. When the transfusion is discontinued, use new tubing for the normal saline infusion. Notify the primary care provider immediately. Monitor their vital signs, blood pressure, heart rate, temperature, blood pressure. and respirations, monitor fluid intakes and I's and O's, and then of course send the remaining bag, filter, tubing, a sample of the patient's blood, and a urine sample straight to the laboratory. Febrile reaction, again, this is sensitivity of the client's blood to the white blood cells, platelets, or plasma proteins. The patient will have fever, chills, warm and flushed skin, headache, anxiety, and muscle pain. So of course, stop the transfusion immediately. Give antipyretics as ordered, notify the primary care doctor, keep the vein open with normal saline infusion. So febrile non-hemolytic, of course, that's the most common type, right? That's caused by antibodies to the donor's leukocytes that remain in the unit of blood. So usually, again, begins 2 hours after the transfusion, chills, minimum to severe, followed by fever, greater than 1 degree Celsius or 2 degrees Fahrenheit. The acute hemolytic is when the donor blood type is incompatible with the recipient, and it's always a dangerous, life-threatening situation. They'll have fever, chills, low back pain, nausea, chest tightness, dyspnea, and anxiety. Eventually hypotension, bronchospasm, vascular collapse, and DIC, disseminated intravascular coagulation, where they clot, bleed, clot, bleed, till they can't clot anymore and they actually bleed out. So very serious. Shows you the main signs and symptoms of an acute hemolytic reaction: systemic wide chills, fever, vascular, low blood pressure, uncontrollable bleeding, transfused vein, heat sensation, pain in the lumbar region, heart rate is increased, chest is constricting, pain, and then of course hemoglobinuria and hyperbilirubinemia. This is a nice picture for the visual learners and all of you who remember pictures, right? Please make sure you know the signs and symptoms of allergic, febrile, hemolytic. And with all of them, remember, our number one thing we do is stop the transfusion and run that normal saline. Reactions by screening blood donors, right? So volunteer donors are preferred. Paid donors less likely to report past or present diseases. So they screen for infectious diseases, hepatitis, HIV, tuberculosis, syphilis, malaria, international travel, if they've been residing in the United Kingdom between the 1980s to 1996, the United States, all of those key things. Blood diseases, abnormal bleeding, hypotension, anemia, jaundice, fever, if they have any high-risk behavior, male homosexual or bisexual, have an increased risk for HIV, malignancy, disease of heart, liver, lungs, allergies, recent pregnancy, surgery, blood transfusion, vaccinated with unattended viruses or live viruses, recent piercings, recent tattoos. Reaction to your nursing care: immediately stop the transfusion, clamp IV tubing, and disconnect a hub of catheter. Do not allow any additional blood to enter the client flush tubing with the saline tube clear, because it goes directly back into the client. So you collaborate with the provider for pharmacological treatment, supplemental oxygen, diuretics, antibiotics, antihistamines, glucocorticoids, monitor hemoglobin and hematocrit, and complete the transfusion reaction form. It's a good point to know this is a guide to drug overdose, right? So you do your initial assessment. Are they having signs and symptoms, right? Symptomatic. Then you look at respiratory support, cardiac and IV support, urinary catheter, I's and O's, right? If they're asymptomatic, you continue to assess. Again, if they become symptomatic, you follow that chain, right? Airway, breathing, circulation, right? The respiratory, cardiac, urinary catheter. And if there's an overdose, you look at other options that might be ordered: gastric lavage, activated charcoal, and make sure you know your antidotes from the antidotes chart, right? Warfarin, vitamin K, Tylenol, Mucamist, right? So those are important things you need to know. And of course, toxicologic analysis, right? UA, blood work, stomach contents. Be very familiar with drug overdose. Of course, it's very important. The nursing responsibilities: all medications must have a signed provider prescription. Administer drug as indicated, typically allowed 30 minutes before through 30 minutes after the prescribed time to give the medication. So prior to administering a medication, know and understand medication incompatibilities. Verify drug safety in pregnancy and lactation. Review hepatic and renal function before administration. Obtain cultures before beginning anti-infective therapies. Know lab values or other tests results prior to administration. Older adults may retain lipid-soluble drugs longer. Serum levels of water-soluble drugs may be higher than normal, and many medications may cause confusion in the elderly. So that's why it's so important to assess these things, especially for the elderly, because of their decreased metabolism of medication. So it's important to understand that these drugs can interact, right? So the quad four, famous four, right? Fantastic four. So TDCI for theophylline, dilantin, coumadin, and inosine, right? Erythromycin. So very important to make sure that they're not given together at the same time. Toxicity can, important things for you to know, of course, can lead to slurred or difficult speech, okay, altered mental central nervous system status, muscle twitching, and seizures with lidocaine. Remember SAMs, okay, slurred speech, altered central nervous system, muscle twitching, tremors, and seizures, convulsions. Make sure you know the therapeutic drug levels in the book, but also the toxic levels. Lithium, digoxin, theophylline. Lithium is 2.0 milliequivalents per liter. Dig is 2.0 nanograms per milliliter. Theophylline is 20 micrograms per milliliter, right? So wow, longest is the highest number, right? So again, you want to make sure that we never go over these numbers. You have to hold the medication and call the provider. If they're toxic and it has an antidote, you have to give the antidote, i.e. like digoxin, the antidote is Digifab. So remember, medications that are teratogenic to pregnant women, so no way during pregnancy. So 2QT, say no to OBs, right? So quinolones and tetracyclines, right? Completely category X, cannot be given to pregnant women. Drugs to lean on, remember lidocaine, epinephrine, atropine, and Narcan, right? So quick, not much time. Along with that, O2, lidocaine, epi, right, for code blue, atropine for heart rate less than 60, Narcan for opioid overdose. Here you have an idea, okay? So isoproterenol, dopamine, epinephrine, and atropine, right? So if the patient is crashing, right, they could use a good idea. So always remember these key drugs. So of course, with overdose of salicylate poisonings, right, you want to make sure, okay, because of ring, tinnitus, right, in the ear, nausea, vomiting, lethargy, excitability, hyperventilation, increase in body temperature. So very important to know when someone has been poisoned, especially a child, with a salicylate like aspirin, right? So severe toxicity can lead to metabolic acidosis and seizures, right? Toxic level for a 30-pound child is 12 adult aspirin or 48 baby aspirin. Remember, it's insulin, right? Mixing insulin, always given on boards. Draw up the clear. Clear is, remember, the fast acting before the cloudy is the long acting, right? So to prevent contaminating a short acting insulin with a long acting insulin. Remember, clear, short acting, fast acting before cloudy, long acting, clear before cloudy. MAOI inhibitors, remember, Nardil, Parnate, Marplan, right? No popular meds, right? So with this, you want to make sure they're not also taking barbiturates, tricyclic antidepressants, antihistamines, CNS depressants, antihypertensive, OTC cold medications, sweating, tremors, elevated blood pressure, bounding heart rate, is what are the things that you can see with those toxic levels, right? So you want to make sure no cheese, no wine, and no pickled foods like pickles, right? So very, very important. Heparin, Coumadin, remember corresponding lab test. Coumadin, warfarin, right? PT-INR. And then remember heparin, right? Heparin, PTT, right? And you can see people remember the H, like two arrows going up to help them remember the PTT and APTT, right? Partial thrombostin time and activated partial thrombostin time. Warfarin, PT boats in World War II. So again, therapeutic levels 2 to 3. Guide to management of a drug overdose. Just remember initial assessment. Are they asymptomatic versus symptomatic? You assess level of consciousness, adequate respiratory function, and cardiac function. looking at their reflexes, right? Pupillary, corneal, and gag and deep tendon reflexes. Of course, usually with any type of drug overdose, especially if they're taken to the ER, they're going to be looking at gastric lavage, activated charcoal, and specific antidotes depending on what was ingested, right? And they're also going to do a toxicology analysis. Our number one concern priority, again, airway, breathing, circulation, right? Respiratory support, assess cardiac function, and possible necessary for urinary catheterization. And remember our ABCs when it comes to our HTN, hypertension, our antihypertensive drugs. ACE inhibitors are our PRILs, right? Beta blockers are LOLs, our calcium antagonists, right? Remember nifedipine, right? But they also include cardizem, right? Procardia, and all those key drugs, right? Verapamil. So remember our ABCs when it comes to hypertension. Beta blocker actions. Remember, you have beta 1, you have one heart, and beta 2, right, which affects the lungs. You have two lobes, right? So these are the receptor sites. Beta 1 acts in the heart, one heart. Beta 2 acts in the lungs. Two lobes for your lungs. So remember, all of my steroids end in ONE. Steroids are the one, right? So number one, anti-inflammatory corticosteroids end in ONE. Anti-cancer drugs, adverse reactions, precautions you want to make sure that you're aware of, right? Bone marrow suppression, so increase the risk for, of course, low WBCs, platelets, low H&H, right? Nausea and vomiting, anorexia, GI disturbances. They cannot get pregnant, and alopecia. Cholinergic crisis, remember SLUD, SLUD, salivation, lacrimation, urination, and heavy defecation. Okay, that's a cholinergic crisis. They're, again, a lot of their mucus, everything's coming out. So excess saliva, excess tearing, excessive urination, and of course, defecation. Medication, so remember, okay, with isoniazid, right? INH, increase, right? The B6, right? So anti-tuberculin, right? Increase the big B6 with levodopa, right? Anti-Parkinsonian drugs, you want to lower the B6. So again, medications, and when it comes to B6 vitamins. Eardrops, remember, the adult, right? Up and back. Child, down and up. Aminoglycoside toxicity, right? So remember, major toxic effects of aminoglycosides are ototoxic and nephrotoxic, right? Gentamicin, tobramycin, acamycin, right? Neomycin, right? So ears and kidneys. Calcium channel blockers. People remember very nice drugs, right? So verapamil, nifedipine, and diazepam, right? So these block the calcium access to cells, causing decrease in contractility, decrease in conductivity of the heart, and decrease for oxygen demand, thus decreasing the blood pressure, right? So the side effects, of course, decrease the blood pressures, and that's also why it's given, but it also has side effects with bradycardia, may precipitate an aventricular block, headache, abdominal discomfort, constipation, nausea, and peripheral edema. So your assessment needs to be on point. This is just a nice slide that gives you the classes of the different antibiotics, penicillins, macrolides, okay, aminoglycosides, tetracyclines, cephalosporins, sulfonamides. And this is just important. Of course, you can see the different bacteria that they affect, but just something I just want to point out to remember, if a patient has an allergy to cephalosporins, and they usually have CEPH or CEF in the name, they will also have a cross sensitivity, meaning that they will probably be allergic to all of the penicillins. So cillins end in CILLINA. So you want to make sure that you don't give them, right? So cillin, CILLIN, right? So you want to make sure, again, anybody who's allergic to penicillin will have a cross sensitivity to cephalosporins. This is a good slide that shows you key drugs that you need to make sure you're familiar with: anticholinergics, cholinergics, opioids, sympathomimetics, and sedative hypnotics, right? So with anticholinergics, you want to see what they do to the heart rate. All of these drugs, right? Do they decrease, increase? And of course, how do they affect respiration, temperature, pupils? Are they constricted? Are they dilated? Are my bound sounds hypoactive or hyperactive, or do they stay the same? And then, of course, are they diaphoretic, increased diaphoresis? Again, are they drying up? Okay, because it's important for you to know that. Detrol here, right? So it says, so you have an overactive bladder. Now with Detrol, you can feel freedom to run, jump, cough, and sneeze again without the fear of leaking. And you can see she needs to go to the bathroom. It says, I can't believe my leaking. I just can't. I just put on a clean pad. Oh no, no pad and nowhere to hide. Geez, the embarrassment, right? Achoo, she sneezed and she's leaking everywhere, right? And now, of course, he's saying his pants are stained. So that's what it's given for, right? Told you, Radine. So you watch for headache, dizziness, dry mouth, constipation, and urinary retention. Remember, because it dries everything up. This, of course, gives you safe administration when it comes to a child. Remember, everything is based off of their weight, right? And the maximum safe dose is based on the child's weight is equal to safe dose per kilogram times the child's weight in kilograms, right? So you always double check calculated doses with an RN. Call healthcare provider if dose is outside normal range. You check heparin, digoxin, insulin, chemo drugs with another nurse before you ever give them, right? And remember the mathematical formula, desired over the dose on hand equals the amount to give, right? Dose desired over dose on hand times quantity is the amount to give for a medication, right? So again, remember parental is the dose desired over dose on hand times the quality of the solution. And infusion, of course, amount to infuse over the hour rate equals the number of hours. Amount to infuse over the infusion time equals the mLs per hour, right? And then, of course, for our get factor, the drop, it's a total mLs over the number of minutes, which equals mLs times get factor, which equals gets per minute. mLs per hour over 60 equals mLs per minute. Great formulas, great slide for you to make sure that you're fully aware of. So again, this is a nice conversion chart. This is something that you need to commit to memory, like you know your numbers, your telephone numbers, like you know your date of birth, like you know your social security number during tax time, right? So again, make sure you know all of your conversions. Equation description, each side of the equation represents the same proportion, percentage, or ratio. So example, 50% equals 50% equals 0.5 equals 3 to 4 is 7.5 to 10 or 75 to 100, right? So you want to make sure you're fully aware of all of those key things, okay? Both sides of the equation represent an equal relationship but are expressed with different qualities. The two sides must. Of course, this gives you the mathematical formulas, right? Lots of practice here for you. So make sure, of course, that if you have any other questions, you send us an email and follow up with our dosage calc section. So this is a nice practice question. The client receives 300 milligrams of phenytoin dilatin by mouth daily for seizures, and the pharmacy sent phenytoin 125 milligrams for 5 ml suspension. How many mLs of suspension will the nurse administer? So you always want to make sure that you're looking at what? Desired over what's available times ml equals ml per dose, right? So for an example, if they gave 450 milligrams over 150 times 5 mLs, that would, of course, give us that calculation, right? So here, desired time mLs over what's available equals to milliliters per dose, right? So for example, if they gave us 300 times 6 over 900, 1800 divided by 900, which would equal 2. Those are just some references. So of course, this order is for 1,000 units of penicillin. The penicillin on hand is labeled 250,000 units per ml. How much of the drug do you administer? So this walks you through step one, and this is a weight-based calculation for you to practice. The child weighs 68.2. The nurse must administer amoxicillin and moxil by mouth at 30 milligrams per kilograms per day in divided doses every 6 hours. How much amoxicillin does the nurse administer each day? How many milligrams of amoxicillin does the nurse administer for each dose? Convert pounds to kilograms by dividing by 2.2. 17 divided by 2.2 is 7.72 kilograms. 60 milligrams times 1 ml over 100 milligrams is 0.6 mLs. Then calculate the dosage parameters. So 50 milligrams per kilogram per day times 7.72 is 386 milligrams per day. Then calculate the prescribed daily dose. 200 milligrams times 3 doses every 8 hours is 600 milligrams per day. And there you have it. IV calculations, of course, you are to administer vancomycin 500 milligrams IV and 250 milliliters of normal saline to infuse over 2 hours. What is the rate in milliliters per minute? So total volume in milliliters over the number of hours given times is equal to the milliliters per hour, right? So of course, looking at here, looking at the total, our sum total divided by 24 hours is 125 mLs per hour. And remember, practice makes perfect. Practice makes perfect. So practice these problems and of course refer to our dosage and calculation problem. But remember, this is an integral part of pharmacology, so you want to make sure that if you're given a math problem, you get it right. So the patient is receiving epinephrine, adrenaline 0.25 micrograms per minute IV. You received from the pharmacy 0.1 milligrams and 250 mLs of normal saline. What rate in mLs per hour should the pump be set at? Get that calculator out, paper, pencil, get that notebook out. Any questions, please reach out, leave a comment down below, and we'll make sure to address it. Okay? Put your questions in the comments. And remember, this is all about working hard to achieve your big dreams of becoming a nurse. So turn that impossible to I'm possible. I cannot change yesterday, but you can change today. Take the initiative and always remember, you can and you will be successful. Thank you for choosing Everyday Nursing.